My name is Amanda. I am the lead nurse for East Kent Hospitals and also founder of the DSN Forum and one of the directors of the DSN Forum. I just introduce some of the other people on the call. So we'll start with the forum team first. So Beth, would you like to introduce yourself?
Hey, yeah, my name's Beth Kelly and I'm one of the lead diabetes specialist nurses for Wiltshire.
Tamsin?
Hi, I'm Tamsin. I'm the lead DSN at the Royal State University Hospital.
Vicky?
Hi, I'm Vicky. I'm not a lead DSN, but I work at Leicester Diabetes Centre in the Eden Education team, and I'm also a community diabetes specialist nurse for University Hospitals of Leicester.
And then we have two very special guests today. I'll let you introduce yourselves. Vicky, do you want to go first?
Yeah, so I'm Vicky Applegarth. I'm a diabetes specialist nurse in Islet and Pancreas Transplant. My background inpatient, but I am now working in community in Newcastle.
Mm-hmm. Denise?
Yeah.
Hi.
Sorry, I thought you were just going to do it.
Hi, my name's Denise Bennett. So I'm not a DSN at all. I'm a transplant coordinator, and my main role is pancreas, solid organ pancreas and islet cell transplantation. That's why I'm here, hopefully to
Amazing.
have some pearls of wisdom.
We have been scouring the country for people that do it for a long time, haven't we? Trying to find people like you guys. So we're so glad. As soon as we saw Vicky post that she did Islet, we were like, oh, we'll grab her.
Get it now.
We're very excited.
Yeah. So before we start, I don't know if you've watched any of our brunches before, but before we start, whilst we're letting everybody sort of join on Facebook, it takes a few minutes to get all of our viewers online. And we just sort of do these little icebreaker questions where we just have a little natter about different things. And we're just thinking, because the weather's been so lovely lately and everybody's having barbecues, we thought we'd go with what is your favourite thing to do on the barbecue? I'll go first. Mine. I make these really lovely kebabs. So they're like chicken, chorizo, peppers, onions, courgette, whatever's in the fridge really. Chuck them all on this kebab. But I had this amazing kind of flavour that I put on it. And it's basically every single herb out of the cupboard. It's like parsley, rosemary, garlic, thyme, all sorts. Oh, we've lost that. So all sorts of different flavors on it, and it just comes out tasting really nice. Paprika, cumin, honestly, it's like literally got every single spice in it, but it's just so nice, so nice. It's it's people come to our barbecues especially for my chicken. Okay, who's next? Vicky.
Oh yeah, this is going to get confusing.
It's going to get very confusing because you can't even say Vicky A.
I'll let our guest Vicky go.
Well, mine would probably have to be a burger, because you can just have so many different toppings on it, can't you? And so many different flavours. So yeah, got to be a burger.
How about our other guest, Denise?
I think, well, I stopped eating meat a year or two ago, so barbecues have become a bit more problematic. I would think I would have a halloumi kebab with lots of veggies and some sweet chilli sauce on the top.
Our friends make these really lovely aubergine kebabs. So if you haven't tried those, they're really quite nice, and they don't fall apart on the barbecue like other things do.
Yeah, that's the problem sometimes.
Who's next? Tamsin?
Well, I was going to say halloumi as well, but I would say I don't eat much meat either, but I do eat chicken, and so probably I would say a chicken sausage or something like that on the barbecue, because I love like putting all the barbecue sauce on and everything. So
mustard and ketchup and onions on a sausage.
Yeah, definitely.
And gherkin. Got the best. I'm getting hungry now. Beth?
I'm pretty boring. I was just going to say a normal hot dog, pork sausage, blah, blah, blah. But yeah, I'm not that, I don't go big on barbecues, if I'm honest. I mean, I like a barbecue, but I don't go big with kebabs and all that kind of jazzy stuff because, yeah, I can't bother to say. Yeah, just a hot dog.
Cool. Right. I think we've got quite a few people joined now online. So welcome, everybody. Thank you for joining. Please share this post so that other people will join as well. And you can always catch up later. We will have this on our YouTube channel probably quite soon. Vicky's very good at that. I will put it on the podcast. We will have it all over our social media sites before probably the end of the day, knowing us. So yeah, well, let's start by kind of getting to know Vicky and Denise. Like, what's your day job look like? Should we start with Denise? What kind of things do you do each day?
So I work Monday to Friday, although I only work part-time, but there are sort of office hours. And my job, really, day job, is working patients up for transplant, so getting them through the assessment process. So that's, as I said before, for pancreas transplant or islet transplant, and then follow up afterwards. So we do follow-up clinics. So that's the main sort of day bit of my job. The bit that's a bit different about my role is that we do on-call. So I usually do about 3 or 4 on-call sessions a month, which means I'm on call for actually taking organ offers. So that's overnight. So that's a 24-hour on-call that you do. And when I do that, I'm actually on call for all abdominal transplants. So that's liver, kidneys, pancreas, islets. So that's sort of the bit that's different. So if I got an organ offer, for instance, for islets, that will be actually starting to set up the process of setting up a transplant. But most of the day job is liaising with patients, working patients up for transplant, and the follow-up care. That's the main aspect.
So when you say working people up for transplant, what kind of things does that involve?
Well, obviously they're referred in. So we book appointments for them to be seen. I'm sure Vicky will expand on this a little bit, but we run a multidisciplinary team clinic where we see all of our referrals. And at that point, often it's not very pinned down as to what the patient or the person might want. They come through with problematic diabetes. So they come in and have a discussion with ourselves, the doctors. We also, lots of patients who come through for pancreas transplant have got renal failure. So they're coming through for pancreas and kidney transplant together. So we have nephrologists, we have surgeons, and we see them very much in a sort of MDT information giving clinic. If the person who's been referred decides that they'd like to proceed, then it's setting up the tests that they need prior to listing. So that's variable. They have an anaesthetic assessment usually. For our islet transplant patients, they need a liver scan because we actually put the islet cells into the liver at time of transplant. All of our patients see a clinical psychologist as well, so we book that. The patients also have a mixed meal tolerance test, because one of the, certainly for islets, one of the key requirements is that they're C-peptide negative. So we do a formal mixed meal tolerance test for that. So we take it actually quite slowly, the assessment process. It can take sometimes several months to get a patient through that. So you're guiding them. As and when the tests are completed, we have again a multidisciplinary team meeting and discuss their case amongst ourselves and decide if it's, yes, this is the right thing to do. Obviously with the patient involvement all along, this is the right thing to do for them or not, and guiding them down another path if that's what they need to do. So I mean, Vicky, I don't know if you want to chip in about the assessment, because we do it together really now, don't we? It's fantastic having Vicky on the team. we've pinched Vicky in the past year or so, because we never had, the problem we had in Newcastle is we didn't have a diabetes specialist nurse attached to this service. So it's really, really been so useful since Vicky's on board with us.
I mean, I guess before we jump to Vicky, do you know how many centres there are around the
UK? So there are 7 centres nationally, and they are all listed on the Diabetes UK website. If people want to go in and have a look at that, there's contact details and things for referring in. To be honest, the main 3 centres that have the busiest group of patients, the biggest group of patients are Edinburgh, Manchester and Newcastle. But there are also 2 centres in London. There's a centre in Bristol and Oxford. So patients can be referred in to any of those services.
Cool. So we'll get to the questions about who we can refer and stuff. How many kind of numbers do you see through your service?
It's a relatively niche market for islet transplant. So we probably see, I mean, we run our assessment clinic once a month, and there might only be 1 person in that clinic who's been referred through for islets. And to be honest, from that, we probably only 50% maybe actually proceed to assessment for transplant. Some of these patients come through and actually just need a bit of their diabetes to be sorted out, and they might be referred into pump services, that sort of thing, locally. So it is a niche, it's a niche market. So we probably only see, we've usually got 4 or 5 patients active on the list at any one time. Edinburgh do have a bigger list because they cover the whole of Scotland, and Manchester have a big list as well because they operate in a slightly different way in terms of the kind of patients that they see. So it is it's a relatively small number.
And I'm wondering if that's because DSNs don't know who we can refer. We're not very that okay with who can have an islet surgery, what kinds of people is it for. So I suppose, Vicky, do you want to talk through who's eligible? Can we refer just to anyone?
Going back to that as well, though, I think as well, it's patient expectation. So a lot of patients do come through for maybe assessment for pancreas transplant, and they might not be suitable for pancreas, so then they might be thought about for islet transplant, but their aim in their head is, I want to be off insulin, I want a pancreas transplant. But so the sorry, just going back to what I've totally butted in what you said.
No, it's fine.
The patients, sorry, what we I've had a complete question.
Do we kind of, do you want to talk about who we can refer and, where we would find guidance for that?
Yeah.
That kind of thing.
For islet transplant, these are the patients that are obviously having hypo unawareness. So we normally say 2 or more severe hypos within a year, which, as you can imagine, is actually not that it's not that many. These patients are having them maybe once a week at least. A lot of the time it's when they're having third-party intervention. I mean, some of our patients that we've seen, they can't leave the house on their own. And it doesn't matter if they're using technology or not, they're just still having those hypos. And then obviously, like Denise said, C-peptide negative. But I mean, a lot of your type 1s, if they've been type 1 for a long time, you'll notice that the C-peptide is extremely low anyway. And then any contraindications to immunosuppression, obviously we wouldn't want to be given a transplant to someone who couldn't have immunosuppression for a particular reason. There's not like Denise, correct me if I'm wrong, but there's actually not a massive criteria for these patients, really, is there?
Well, no, certainly for islets and pancreas alone, it's that criteria of being C-peptide. So it's national guidelines from NICE, and you're right, it's 2 severe hypos within the previous 24 months, and that's meaning basically third-party intervention for the hypos, and hypoglycemic unawareness that, as Vicky said, is causing real life-threatening, but also life reducing in terms of being able to live a full life issues. But to be honest, in Newcastle, we will see people, and even if the criteria aren't strictly met, we'll see them and just help guide them. Otherwise, we'd rather see people and talk to them than say you can't come here because you've only had 1 severe hypo in the past year. We'll see them and talk it through.
Sometimes it's like us giving bit more of a specialised advice as well, like not saying that we're better than anyone else, but like sometimes they might not be getting the best care that they could be. Maybe it's partly because of them not asking for the help. So I can think of one lady that had came in and she was on a Dexcom, but she was still having really, really severe hypos. But I think since COVID, just sort of like our appointments and everything like that had been missed. So it's just getting her linked back into her provider, because obviously we're not there to take these patients away from their local provider. Like, as you're aware, we're a tertiary centre, so we want their local provider. We're all of us to work together as a team, to obviously get the best for the patient.
It's interesting, because you do think that does seem quite a lot of, when you say the eligibility, I thought it would be much stricter than that. And I suppose quite a lot of us have definitely got patients that we're seeing that despite the use of tech, despite pumps for whatever other reason, they're still having those severe hypo episodes. So
Technology
we'll be getting a flood of referrals come Monday now.
Yeah.
Do you take referrals from DSNs? Does it have to be a consultant?
As long as you're attached to a consultant, we'll work it out. Work it out. And we just take we'll take an email referral. And as I say, we'd rather see people and talk to them about what we can offer, and take it from there. So, I mean, the other thing is that they are the absolute criteria that we outlined. We do for both islet and solid organ pancreas transplant. We don't like people to be too fat. So that's something that we sort of have as a thought. It's not an absolute, just because certainly for solid organ pancreas, it doesn't go well. We say your BMI should be below 30. And for islets, it's a little bit complicated, but we know that the lower your weight is, the less islet cells you actually need to have transplanted to hopefully get the outcome that we want. So weight is an issue. Not being on too high insulin doses. If someone's really needing a lot of insulin, then sometimes the outcomes can be a bit less. But they're the sort of things that we discuss when we see people, really.
Would this just be for people with type 1 diabetes? Can you do it for type 2 as well if they've got low C-peptide, or is that?
We haven't. The other group that we have done in the past is patients post-pancreatectomy. So we've done it in that group. We also, the criteria are a little bit wider for patients if they've had a previous transplant. So if it's someone who's had a kidney transplant previously, we're not as strict about the rules aren't quite as strict, because that group of patients is already taking the immunosuppression anti-rejection medication. So the risk-benefit ratio is a bit different. I'm trying to think about, but yeah, type 1 is, we certainly haven't done an islet transplant in a type 2.
Okay. I just want to put a shout out to Facebook, because there's a lot of people watching, but you're very, very quiet. So please do ask all the questions. This is live. We are right here, right now, in our various living rooms and bedrooms, and we will ask any questions that you have. So please do put any questions that are relevant to the topic onto the Facebook post, and we will answer them as soon as we get to. So I think our Vicky had some questions that we pre-prepared for you. So Vicky, did you want to start with those? Did you want to start going on those?
Yeah. So I guess this is a bit like a two-pronged question, really. So firstly, what is the kind of ballpark figure of success rate with islet cell transplantation? As in, I'm guessing the ultimate aim is to not require insulin any longer. And after that, obviously the use of anti-rejection medication. I used to work on a transplant unit, so I know that some of the medication used in anti-rejection can actually have an effect on glucose levels. So do you see that as well? So sorry, two questions.
So when it comes to success rate, I think because we've got such a small group of patients that we have, like you say, the ultimate goal would be insulin independence. But I think, especially for me, the way I see it is if you can improve their quality of life, because obviously their hypos are really severe. And I think most of the patients that we have done massively improve their quality of life. But also, it's not, so we don't just do one transplant and that's it. Because it's an infusion of islet cells, normally they would have 2 or 3, and we are trying to get these done within a shorter space of time, because of the immunosuppression that they are having on induction. So if we can try and get them in with the first 3 months, say we get the second one, obviously we've got better success rates in that way. We have got a patient quite recently who's had 2 done within the space of the 3 months, and she was on a Medtronic 780, and she was on 18 units totally daily dose. She's now on 0.9 on a day. And actually, because she's so soon on, we haven't, because we normally use a lot of type 2 drugs. So we use dapagliflozin, we use sitagliptin. And if we restart some of those drugs, maybe we probably will get her off insulin. And we use metformin a lot as well. But then talking about immunosuppression, so I used to work on the transplant ward as well, and I know tacrolimus, because we use tacrolimus in these patients, obviously can sometimes increase your blood sugars, but actually what I've noticed with most transplant patients, it's the steroids, and we don't use steroids in the islet patients or pancreas patients, partly for that reason. But I know across Europe, I went to Austria in January for the islet, like ESOT, and they use steroids for when patients are rejecting. So they have quite a good success rate in that sense, but I suppose it's just something we've never done.
Yeah, you know, when I worked on the liver transplant unit, we used to treat them with 3 days of high dose prednisolone for if they were signs of rejection, and that just used to cause absolute havoc with the glucose levels.
And the way they do it, what I found out is, because I was very intrigued, that they basically put them on IV insulin for the 3 days that they're on the methylpred. But I know from working on the ward, I know that just wouldn't work. But we've never had to do that so far. But yeah, I've not, with tacrolimus, I've not noticed, especially with pancreas transplants, because I think you can see it a little bit easier because they're not on insulin. Obviously the islets, if they're still on insulin, then they've obviously got so many different factors that could have increased their sugar. So you can't really say, right, it's definitely the immunosuppression. But yeah.
Interesting.
Oh, so we can tell this is live because Vicky's camera's got so which maybe she might try it on and off again in a second to try and get it back working again.
We can still hear you though, so it's
we can still hear you, so that's perfectly fine. So the other questions, lots of questions come through on Facebook. Camden, did you want to read a few of those out?
Yeah, so the first question that came in was regarding the BMI, which you said that you would prefer obviously for it to be below 30, but is that a negotiable criteria? I think I'm assuming it is, because I think you've said, haven't you, that obviously that's what you would prefer, but it depends, I'm assuming, on the person.
Yeah, certainly solid organ transplant, I think we've sort of unofficially renegotiated to about 32, but that's bearing in mind everything else that's going on with that person. So yeah, that is negotiable.
Okay. And I think the other question I think it was from the same person, that they said that their closest centre is Bristol. So they just refer directly to their local centre, do they? Or is there a national sort of referral pathway?
No, if they refer to the local centre, I know Bristol is having a few issues with their Islet programme at the moment, and they're being sort of looked after by Oxford, just because they weren't getting the numbers through, so they weren't actually doing many transplants. But there's still the contact in Bristol will be the person to get in touch with. Can I just stress just go back a step, actually, just to something that you talked about getting off insulin being the main aim. For islets, we don't sell it like that. And it's not really with the NHS England commissioning. It's to actually be able to get rid of the episodes of severe hypoglycemia. And we really have to stress that to some of our patients. As Vicky said at the beginning, it is about expectation management. We do know that getting off insulin is absolutely the best treatment to get rid of those severe hypos, but we try not to oversell that. For solid organ pancreas, if it's successful, you will be off insulin. For islets, not necessarily. And often that people might be off insulin for a period of time. We've had a lady who was off insulin for a few years, but is back on low doses now. But the field, it's changing all of the time. Again, at the moment, we're looking at the possibility of just retransplanting people as things maybe decline a little bit, to just give them another transplant to get them off insulin. But officially, it's not the reason for transplant.
Yeah, I was just going to say that, actually, because obviously you said that you might do sort of several infusions in the first 3 months, and then I was going to ask, so after that 3-month period, is that it, or do you then
it depends
at a later date?
It depends on what's happening with their function. Someone's asked about success rates in the questions I noted. I don't know if I'm jumping ahead.
Don't worry.
But it's really hard in islet transplantation to measure success. Solid organs relatively easy because you're off insulin. So as long as you're off insulin, your pancreas is working. If you're not getting someone off insulin, it's a tricky measure. So we do that by measuring. So the C-peptide negativity that we talked about at the beginning, where afterwards we're measuring C-peptide regularly in clinic. So you'd love to see these patients having rip-roaring amounts of C-peptide. So we're looking at that for success. And obviously, just are you having severe hypos? And there are figures on the NHS Blood and Transplant website. They produce a paper annually of measures of success. So it's how much insulin are these patients taking? As Vicky said, insulin requirements go down. How many hypos are they having? What's happening with their HbA1c? So it's a bit more, it's a broader measurement in terms of islets for success. Are
they still coded, or they still have a diagnosis of type 1 diabetes regardless of what's happening with their insulin requirements and things like that?
Even when they've had a pancreas transplant as well, because a lot of patients ask that, because we would never want them to be discharged from their diabetes care, because, you know, a pancreas might last them a year. They might be very unfortunate and that might be them. So we'd always want to make sure that they still get seen annually.
Yeah, this is the issue I had with one of my patients when I was working in the GP surgery doing a pilot for a couple of years. And the practice nurse was ringing up, you know, I need to do your diabetes checks. And he's like, I don't have diabetes anymore. And he got very, very upset with her. He's like, I've had a transplant. I don't have diabetes. Well, actually, yes, you do, because it's autoimmune in type 1 diabetes, isn't it? And so, you know, sometimes I'm guessing that autoimmune will attack the new pancreas. Is that what happens?
Can do. Certainly pancreas and kidney together. So as I said, the vast majority of our solid organ pancreases we do in combination with a kidney, because they've got kidney disease as a consequence, usually of their diabetes. And they seem to protect each other. So the sort of length of time those grafts tend to keep going is relatively long. We've got patients sort of post 10 years with successful grafts. Pancreas alone, the outcomes are potentially not so good. But again, these, in terms of your diabetes follow-up, nothing's going to reverse the damage that's happened to your body before. There's not a lot of reason. There are some people who think some nephropathy, some sort of nerve damage might improve, eyesight might improve, but there's nothing research-wise to absolutely prove that. So having your annual checks is still absolutely. But some patients just, as you said, I haven't got diabetes anymore, and they just back off. So it's just trying to keep, I mean, we try and have some contact with all of our patients at least annually, just to reinforce those kind of messages. So, you know, that even if it's a telephone appointment, it's, have you had your feet checked? Have you had your eyes checked?
And I suppose also from the safety perspective, you know, they will still need access to obviously all the glucose monitoring equipment, ketone testing, for example, if they become unwell, even if, you know, their insulin requirements have dramatically reduced. Obviously, I'm sure there's still the risk there that when they become unwell, they would still need to check all of those things.
Well, we've had patients that have been referred to us, say they've moved location, and they might have had their pancreas transplant many years ago. And then when you start saying, because we want them to still check their blood sugar, obviously not as often, but when you say to them, oh, have you checked your blood sugar? I wouldn't even know how to use a machine anymore. They just totally forget about it, which is understandable. If you do want to try and forget about it, but it's just getting them to just doing the odd checks. And sometimes our diabetes consultant wants them to do like a daily profile just one day a month or something, just so we can see what their postprandial blood sugars are doing. But yeah, and I think a lot of people sometimes as well think they can test their pancreas with food, which we have had recently. I think we've got one person who's now got type 2 post having.
Wow.
Yeah. So I mean, it's, you know, it's with all transplants, it's also about looking after yourself, so, and looking after your organs, isn't it? So
yeah, so someone's asked actually, is there anything we need to do as DSNs who are not in this area normally? Is there anything we need to do for those people that have had this differently? So I'm guessing, would they then not qualify to have like tech and stuff on prescription, or do they continue using that? Or like you said, we want them to kind of go back to some kind of normality, but I guess would they take their pump away and they'd just be monitoring with finger pricks, I guess? Is that what you sort of...
Yeah, so obviously with pumps it would be taken away because they'd be off insulin, but we've had patients recently who may be on Libra and they've said, oh, I've still got my Libra on, and we're like, well, that's absolutely fine, that's up to you. Whereas some people might just be like, oh, I want rid of this, and then we could just, you know, they can go back to just going to a normal finger prick. I know in Newcastle that I would still probably keep in contact with them every now and then, and like Denise said, would see them yearly anyway. And we are doing a little bit of like outreach clinics to our local areas as well, to sort of put that message out there as well, so that they don't totally disregard.
I guess the psychological issues that come from severe hypoglycemia, and there's, you know, a lot of the time they're absolutely petrified, very rightly so, of having I suspect they'd want to keep their CGM for a little, just because they'd be really worried about it. So I guess
massive like lifestyle change. Like it's like when you go and see them post-operatively, they're just in so much shock. And I think for me, like when I used to work on the ward, that seeing the pancreas and kidney patients was one of the best, like seeing the outcomes at the end, because they were obviously just amazed that they're not injecting every time they're eating, and it was just really nice to see. And say they were off dialysis, that's obviously a great thing as well, but it's, some of them do get, you know, shocked like at how much of a change that their life is.
Yeah. Do they get support from, like you mentioned they saw a psychologist, do they get support for a time after the transplant from that psychologist, or is it kind of just a pre-transplant thing?
I'm not really sure. Denise, do you know?
No, they can't, if it's necessary, they will. I mean, it sounds like it's wonderful, and it's a stretch service like everywhere. So they have at least 2 appointments pre-transplant, but if there's anything, I mean, we've had a lady recently who's re-engaged with the service, and they will do their best. They're there as a point of contact, so the support is there afterwards, as much as possible.
There's a question come through on Facebook. What is the chance of rejection, and what step can be taken to prevent rejection? I suppose this is all your...
So all of the patients, everyone who has a transplant, no matter what transplant you have to go on to, sorry if I'm teaching people to suck eggs.
No, not at all.
Everybody, heart, lung, liver, kidney, everyone has to take a group of medication called immunosuppressants, and the job of those drugs is to what it says on the tin is to suppress the immune system in a way that the organs that you've had transplanted, the cells that you've had transplanted, are happy to live alongside you in their body. It's your body will never recognize those cells as self, but it's just suppressing your immune system in such a way that they're happy to sort of live as content neighbors, if you like. So those medicines are an absolute non-negotiable. You must take them, because if you don't take them, you will lose your transplant. So that a part of the assessment process that you asked at the start is really stressing that fact to people going on the list. You know, everyone could have an upset tummy or a day where they're vomiting. That's fine, but any prolonged period of time without your immunosuppression, you will lose your graft. So that's the main thing. And then it's protecting yourself in terms of just being fit and well and living the best life that you can after, keeping slim if you can, going to your follow-up appointments, all those kind of things, so that we can, if things are going a little bit awry, then we can detect it early and do something about it, because we can, what we call, augment someone's immunosuppression. We can change it. It might mean taking higher doses for a little while, just to try and settle things down. I think sometimes people hear the word rejection and they think that's it, everything's gone, I've lost my graft, lost my transplant, but it doesn't. It's just it's a process that can be reversed if detected early. So that's all part of that workup at the start, just to make sure the patients are aware of that. So follow-up and medication, regular blood testing is how we try and prevent rejection. And I can't remember what the second bit was.
Just if there's anything else that we can do to prevent it, but I think it's just that thing, isn't it?
It's just
telling people to keep taking their meds.
Keep taking the tablets.
And what are the common side effects, obviously, to these medications? What warnings do patients maybe get that they can or can't do maybe with these medications?
Well, again, it's the same for every transplant. So what you're doing is suppressing the immune system. So certainly in the first short few months post-transplant, we really encourage them to avoid infection, because you're suppressing the immune system. So the most common side effect is susceptibility to picking up infection. So they're on a bit of an extra cocktail of meds anyway for the first 3 to 6 months. So they're on an antiviral, they're on an antibiotic, but just being careful. So again, that's part of the education process. You know, if you've got grandkids running around, is my example, who've got chicken pox or something, absolutely not, keep them out of the way. Dodgy takeaways, all that. So we go through all of that. So infection's the most common, but there are some more serious side effects, which are an increased cancer risk to certain kinds of cancers. So again, that's part of the counselling that we do pre-transplant and the education. The most common cancer that they're more susceptible to is skin cancer, and on beautiful days like we've had, lots of education about sunscreen covering up, you know, and lots of our patients, some of our men, the tops are off, they're sitting outside, and you can do that, but you need to be, you know, sunscreen, and just being careful. And we do have and all transplant centres should have a dermatology rapid response access. So again, it's education to the patients. Anything unusual, let us know straight away. And then just encouraging them to keep up to date with all of that, with the screenings, breast screenings, cervical screening, that kind of thing. Other side effects are gastric upset, certainly in the initial few months post-transplant, but we just manage that by altering doses, and sometimes altering the actual formula of the medicines. There are some that are more expensive, but less sort of irritating on your gut. So we can use them if that's an issue. So it's just, again, it's part of all of the workup to transplant, and it's reinforced when they're in, having their transplant ready for discharge, the things to look out for and watch out for.
Another question I had was, does someone's HbA1c have to be a certain level? Because quite often they won't do certain operations with a higher HbA1c. So do you guys, I mean, I'm guessing,
no, but I mean, you know, you could have someone that's really high, but actually getting them in and getting that referral, getting it started. I mean, sometimes an average wait for, say, a pancreas transplant could be up to 2 years. So then you've got that time anyway. Now that you've got them in, you could also work on the HbA1c. If you say to them, you know, we do want it better for surgery, then we've got the time to work. And also, if they say they're all worked up and they get put on the transplant list, we don't just leave them there and then never see them until they're transplanted. Like Denise will, you know, organise appointments for us to still see them at the MDT clinic, maybe every 6 months or so. So it's that opportunity to be able to help them there as well.
Amazing. And what would mean someone would have a pancreas transplant over an islet cell? When would you, is it because they need a kidney one as well that they would get a pancreas?
Yeah. Usually, as I say, the solid organ goes with the kidney, but even if not, sometimes it's just personal choice. A pancreas transplant's a big operation, so you do need to be fitter to get through that. So they tend to be younger patients, slim patients, but we put them through a formal anaesthetic assessment and just work out what their sort of risk from that side of things is. So it tends to be a bit of a personal choice, but also are you fit enough to survive a solid organ pancreas? I mean, it's a big 6-hour operation. It involves a stay in critical care. Islet transplantation is a procedure done in interventional radiology. So we take on board patients who are really frail or more frail, although they do have to, you know, it's still a thing to go through. So usually it sort of works out for itself what the best route for them might be. I mean, some of our Islet patients, we've got ladies, you know, in their 70s who go through it as long as that's what they want to do. So it tends to be a fitness thing at first level and personal choice. I mean, the immunosuppression's the same. Whatever you do, the follow-up is more or less the same. You still need to come to clinic, have your blood tests, your immunosuppression levels checked. And a lot of it is how much someone, and Vicky, you're probably better at this than me, how much someone hates their diabetes is what we say. If someone is absolutely exhausted by the constant looking after of their diabetes, then solid organ pancreas is probably the better thing, because then it's not really an issue after, because you won't be on insulin. So that daily battle isn't there. Whereas actually the islets, we ask a lot of them, don't we, Vicky? It's a lot like home.
Yeah. And I think as well, like sometimes once they've came and had the chat about a pancreas transplant, they're like, oh no, that sounds really risky. Like, I don't think I want to go ahead with it. Because sometimes it's like, they might just, all they know is when they come through the door is, oh, I'm going to get a pancreas, I'm going to get off insulin. Well, actually, no, it comes with, obviously, like Denise said, it is a big risky operation. So sometimes they just don't want to put themselves through that.
Yeah.
But there's a few questions on Facebook where I just want to make sure that we get this one in there. So I think Beth had a question about type 3. Did you want to do that one first, and then we'll answer the questions on Facebook?
Oh, well, the type 3, I mean, we were just going to ask about type 3 and Vicky Applegarth, and not Vicky Applegarth. Well, both of them actually. Both Vicky's are kind of a little bit obsessed with type 3 diabetes. So we just wanted to give enough time to talk about that, really. So if you want to answer the questions on Facebook really quickly, then we can do type 3 for a little bit.
Okay, so the questions on Facebook. The first one is, what is happening in UK RE research for islet cell transplant that does not require immunosuppressants? Is there a lot going on in that area?
There is. We were talking about this yesterday, weren't we, Vicky? So there's a project launching probably sometime in the next, hopefully, few months, hopefully this year, which the aim, it won't be to start with, but we are looking at how can we deliver immunosuppression-free islet transplantation. We're not there. We will get there, but we're not there yet. But there is research project, hopefully starting sometime this year, which lots of the Islet centres are going to be involved in, actually. It's not just Newcastle. So keep your eyes peeled for that one. But it's what we're looking at. That's the focus now, really, is because we've got lots of patients, again, as Vicky said, who come through and they go, oh, no, I'll wait. I don't want to take the risk of the immunosuppression. So it's what we're looking at now.
Okay. And then another question, which I'm going to direct at Vicky this time. If transplant rejection does occur, what are the signs and symptoms to look out for?
So, well, I suppose with both of them, you're going to see an increase of the blood sugars. That's probably the first sign that you're going to see. It's very hard to find rejection in an islet transplant patient, because actually with a pancreas and a kidney, you can look at the, the amylase, you can look at the creatinine, you're going to be able to see the difference. But with an islet transplant, all you really got is your blood sugars. So your blood sugars as a start, and especially with the pancreas transplants, we try and say we don't really want your sugars over 8. When they start getting above 8, that's when we start thinking there could be early signs of rejection. But like I said, if they've got the kidney with it as well, that creatinine might have gone off, and it might say that their kidney is rejecting more than the pancreas. But they can do other blood tests as well, just to see, especially with the islet transplant patients.
Wow. Let's go on to type 3 now. What was your question? Because we haven't got a lot of time left and we're going to run out. And I know that Vicky, this is your kind of like baby. Both Vickies love this type. Well, don't love the type of diabetes. You know what I mean? They like the research and stuff like that. So go for it.
Can I ask you, Vicky, then? So obviously it's been diabetes week this week, and I saw you tweet something along the lines of 87% of people with type 3C diabetes have been or are misdiagnosed as type 2 diabetes, which is a massive amount, isn't it? So I guess for those who don't know what type 3C diabetes is, letting people know what that is and when people are diagnosing, what things they might need to look out for that might lead them more towards a type 3C diagnosis rather than obviously type 2, which might not necessarily be accurate.
So type 3C diabetes is basically if it's to do with the pancreas, so exocrine insufficiency of the pancreas. So you might have a patient who's got chronic pancreatitis and then they get diagnosed with diabetes. You might be thinking, right, that means that they'll probably have 3C. Obviously, anyone who's had a total pancreatectomy, we class them as having 3C diabetes, although we want them managed as type 1. This is where it gets slightly complicated, but the way I always tell my patients is if you go somewhere, especially, that you might think, they won't know anything about 3C because it is so new, just tell them you've got type 1, better safe than sorry. And then you've got patients who are might have had a partial pancreatectomy and developed diabetes because of that. They would be classed as 3C. And then also because of CF related diabetes, actually, because of the reason that these patients have got diabetes, they're classed as having 3C.
So I just want to clarify, CF, cystic fibrosis?
Yes, cystic fibrosis, sorry.
You've got people from all sorts watching this, people with diabetes, nurses, don't always know what all these acronyms means, but carry on.
So then it gets slightly complicated, I think, especially at diagnosis, because what you want to know is that C-peptide. So we've started doing it on our inpatients, because we cover like the HPB wards, so a lot of those, if they've started with high sugars on the ward, we'll just do a C-peptide and random glucose, so that we can see where we're starting at and whether or not we can think about stopping insulin later down the line. And then, so I think the patients that are getting misdiagnosed, I think there's been a lot of patients with pancreatic cancer, so they might have come in with sort of like the gastric signs, and then they've done like HbA1c on their test and they've seen that the HbA1c is high, and the GP's only really got in their head type 1 or type 2, so then they'll diagnose them with type 2. But actually, because further down the line they get the diagnosis of pancreatic cancer, well, actually it was 3C to start with. So we do see a lot of that, especially in the patients who have come in for a total pancreatectomy for cancer reasons. They might come in and it'll have on their past medical history type 2 prior to their surgery. When you talk to them, it's even just finding out the information or when they were diagnosed, and then actually they were 3C all along. I had a patient recently who had alcohol chronic pancreatitis, and even I just looked on his GP record and he had pancreatitis back in 2016 and then was diagnosed with type 2 diabetes in 2020. So then when I had a chat with him, I mean, he was really slim and he's always been slim, and his diet and lifestyle wasn't, you know, too bad, obviously, other than the alcohol. So we decided he was actually 3C, and then we've done some more tests.
So a question, sorry, I'm taking over. I've got another question.
You go.
Yeah.
So obviously people who have had total pancreatectomies or partial pancreatectomies obviously are going to need insulin. Well, certainly the total pancreatectomies, maybe with the partials. But for the other patients with type 3C diabetes, so for example, those people maybe who have chronic pancreatitis, for example, what treatments do you tend to use insulin in all of the patients with type 3C diabetes, or does it depend?
So if they're acutely unwell and we've found the diagnosis in hospital, insulin's always going to be our first line. But we do use metformin a lot. And a lot of the other medications, like one of our diabetes consultants is that her main patient group is 3C. And there is patients, you know, there might be a patient quite recently actually come through for their annual review and they were asking about GLP-1s. And yes, although a GLP-1, one of the side effects is pancreatitis, it's all about just keeping a close eye on them. We've started a lady on it because she really didn't want to be on insulin anymore. So we started her on a GLP-1. She hadn't had about a pancreatitis for about a year. And actually since starting it, her HbA1c's come down, she's lost weight, she's had no signs of pancreatitis. And it's just about keeping a close eye on their bloods. But most of them pretty open to trying, but I suppose because it's hard because they're not officially licensed, because 3C is so new, and like on NICE guidelines is basically talking about how 3C patients are entitled to whatever a type 1 patient can have. But also just to quickly mention, I said to Denise, I'd throw it in, it's got nothing to do with Denise, but I don't know if you've come across patients who have had a total pancreatectomy and auto islet transplantation as well. So there's another group of patients, so they'll have their pancreas removed for maybe chronic pancreatitis, hereditary, idiopathic, and then we'll take their own islet cells and put them back into their liver. But these are patients who haven't already got diabetes.
That's exciting stuff.
Yeah, so that's another group of patients that I sort of look after as well.
Wow,
it's fascinating.
I mean, I love doing things like this because it's stuff that it just goes to show how big diabetes is and how much room there is and scope for DSNs to kind of move into other specialties. And when it's really easy to kind of, when you're in the social media bubble, to think all DSNs do is put people on hybrid closed loop or deal with it, and it's like that is a tiny bit of our job compared to how like the breadth that we can do. So can DSNs, you know, where can we learn more, or can they come and spend a day with you? I mean, it's a bit too far to trek to Newcastle for me, but if we're ever up that way, you know, or if anyone's like, can they come and spend a day with you, or can they do anything
like I'm all for getting the education out there, because like obviously I've been saying is especially more secondary cares or even primary care, they don't know enough about it. So I know I'm doing a bit of teaching with the GPs in our area, especially on 3C, coming up in September. But no, definitely if anyone did want to contact us or anything, they can always drop me an email. I am coming to the DSN Forum in October, so that'll be nice.
We'll put you in the corner and direct everyone to come and speak to
we'll
you.
give you a little stand, a little table.
But no, absolutely. I mean, I love teaching, and it is a passion. Like, I really do love it. So
you and Vicky are literally two peas in a pot. Like,
And there's really not very much information out there about type 3C.
No.
Is there
But
specific,
just to
the
mention
specific?
as well, one of our diabetes registers is starting a PhD and doing bit of research in type 3C, and she's actually going to be doing she's taken chronic pancreatitis patients, whether they've got 3C diabetes already or not, and it's all in the start. So she was saying that hopefully what they'll do is put maybe a Libra on them, even if they haven't got diabetes, and just seeing how the deterioration is and how quick it can happen. Because I mean, we've had a patient quite recently who deteriorated within the space of 3 months, had a great C-peptide, didn't need insulin. 3 months later, came in with DKA and a HbA1c of 180. So it just shows you how much it can change in such a short period of time. So that research will be amazing.
Wow,
Exciting.
I think that kind of brings us to a bit of an end, but I want to end on a positive maybe. So is there sort of some words of wisdom you can give DSNs or practice nurses, whoever are listening to this, or people with diabetes? So I just want sort of one sort of roundup sentence from each of you about, you know, something that you,
if in doubt, refer. Refer them in. Just refer people in. We'd rather see people and talk to them and say this probably isn't for you, than people not have at least the opportunity to explore the options that they have.
And also to sort of add on to that is like, we're not here to be like, we want that patient, we don't want to take these patients away, we want to work together as a team. Like, we all have different skills and we all want to work together for that patient. So as much as they come to see us, maybe they've had the transplant, and they need to have their local provider. I mean, we don't want them to have to stay in Newcastle because they come from such a large area. They need somewhere local. So we want to all work as a team.
Lovely. Well, I just want to say a big thank you to our special guest today. And if you haven't managed to watch the whole of this, we will have it available later on YouTube and on the Facebook page. We'll also make it into a podcast so that you can listen to it on your way to work if you want to. And I think we'll just sort of talk about our next one, which is in July. What date was that? 1st of July? Is that sounds about right? We're going to do one on obesity, and we have a fantastic doctors with us. We have Stephanie
DiGiorgio.
It's difficult to say, isn't
What a great name though. Love it.
Brilliant name. She's a brilliant lady as well, isn't she? And Dr. Patrick Holmes. I think all the stuff that we've had in the news lately about GLP-1s and whatnot, I think that's really going to be very useful. So if you're around on the 1st of July, 10:30 this time, we will see you again. Thank you all for coming.
Yeah, thank you.
Bye.
Thank you.
Bye.